get started, Zane?
Yes, we can.
Great. I can hear you and see you. That's great.
Thank you. Thanks very much. I'm Zane Cohen, director of the Zane Cohen Centre for Digestive Diseases, and we are thrilled to be able to put on this Lynch syndrome education night for everyone. We have, I believe, a record number of participants tonight, over 300, I understand. And we have some great speakers. We have very, very important topics. And I think we will get started. A few housekeeping matters, first of all. For those of you in the audience, we are going to have a question and answer period at the end of each talk. And that will include you being able to ask questions through the chat line and through the question and answer line. And these questions will be vetted each time by one of our genetic counselors. So hopefully, technically, this will work out well. And here's the instruction. You can click on the chat in the meeting controls, enter your message in the chat window, press enter. That will go to the hosts and to the panelists. And one of the panelists will then repeat the question, and the speaker will answer the question. I may enter a few of my own words as well, if I can, and hopefully it will all go very well. So the first speaker tonight is Dr. Helen MacRae, who is my colleague, my very senior colleague, not senior to me, but a senior colleague. And she is an expert in IBD surgery and colon cancer, and she is going to speak on gastrointestinal cancers screening in Lynch syndrome. Now, a word to our speakers just before we start, that each has 15 minutes, and then there will be 15 minutes for questions and answers. And I hope that we can keep to time. We're going to start now. We should be finished by about 9:30 at the latest. So let's get started with Helen.
Sorry, I was having trouble unmuting myself. So it's a pleasure to speak to, it looks like over 100 people already have signed on. That's fantastic, fantastic turnout. So I'm going to speak on gastrointestinal cancers and Lynch syndrome screening. So just as since there are lay people, and just as a reminder, the gastrointestinal tract is basically a tube that goes from the mouth to the anus. And the places that we're really talking mostly about screening for gastrointestinal cancers are the stomach and the large intestine. The small intestine, you can get the occasional cancer, but they're actually pretty rare. So the biggest place for screening in Lynch would be the colon and rectum. So this is the large intestine, also known as the colon and rectum. The right side is where the small bowel and colon meet is the cecum, the ascending colon, transverse, descending sigmoid, and rectum. And in Lynch syndrome, the cancers tend to be more in this area as opposed to here. And so to reach them, to be able to see the whole colon, we really have to do a full colonoscopy. So what are the colorectal cancer risks in Lynch syndrome? Well, it really depends on the genetic defect. So of the mismatched repair genes, you can see that the cancer risk is quite different whether you're MLH1 MSH2. These are the highest risks of developing colorectal cancer. And you can see by the age of 75, it's almost 50% of patients with these genetic defects will have developed a colorectal cancer. For MSH6 and PMS2, the risks are much smaller. This just shows you in a different way on a graph, looking at the colorectal cancer risks. So males are in dotted lines, females in the solid lines. For MLH1 and MSH2, the risks are quite high. MSH6, much lower, and PMS2, lower still. So the Familial GI Cancer Registry, the colorectal cancer screening recommendations are, what we recommend is a colonoscopy as the best test. FIT and fecal occult blood tests are not substitutes for colonoscopy, and we'll talk about why in just a second. Every 1 to 2 years. For the highest risk of patients, we start at age 20 to 25. That's for MLH1 and MSH2 patients, and beginning at age 30 to 35 for MSH6 and PMS2. Or if there is a younger, like the youngest Lynch patient I've seen was 18. And so in those families, we would recommend family members start 2 to 5 years younger than the youngest diagnosed colorectal cancer. Now, other tests like FIT and fecal occult blood tests are not substitutes for colonoscopy in Lynch syndrome. And the reason for that is that with these tests, you tend to find more advanced lesions, like to the point that if I'm booking a FIT colonoscopy, I'm expecting I'm going to find something big. And so I book it for a longer colonoscopy. And in Lynch syndrome, because you go from normal to cancer much faster, you don't want to give it that time. You don't find the little polyps that you want to find with FIT testing. And so FIT testing, if you have a genetic predisposition, is not good enough. Comparing our guidelines with other guidelines, the National Cancer Consortium guidelines, colonoscopy every 1 to 3 years, beginning at 30 to 35 for PMS2 and MSH6. And similar to ours, 1 to 2 years, beginning at 20 to 25. Now, I have to say that, we're maybe slightly more aggressive, but when you tell people every 1 to 3 years, it pretty quickly becomes every 3. Similarly, when you say every 1 to 2 years, I have to say the majority of patients, it's more like 2 than like 1. And so I think if we start stretching things out too much, you just don't see people enough. The European guidelines, again, are a little bit more lenient on the scopes than our guidelines. So PMS2, colonoscopy every 5 years, beginning at 35, every 2 to 3, beginning at 35 for MSH6, and every 2 to 3, beginning at 25 for MLH1 and MSH2. I have to say that even though we say every 1 to 2, it's the rare Lynch patient that we see every year. So why do we do colonoscopies often? Well, first of all, polyps may grow faster in people with Lynch compared to general population. So in general population patients, we feel that if you do a scope every 5 to 10 years based on their history and their history of polyps, you're going to catch polyps when they're early and before they've developed into cancer. But that whole polyp to cancer sequence probably occurs faster in Lynch. And so the idea is you want to catch polyps small and before they become cancerous. This was a Lynch syndrome colorectal screening study where they looked at, it was a prospective cohort study where colonoscopy was recommended every 3 years for Lynch patients. And you can see it's quite a while ago because we recommend it now to everybody. Screening, 113 patients were screened and 119 didn't want to be screened, so didn't have the colonoscopy. So if you look at developing colorectal cancer in screened patients, it was 6% developed over the study period versus 16% that were not screened. But I think more importantly, if you look at the stage of colorectal cancer, patients who were screened and developed colorectal cancer all had an early colorectal cancer. So stage 1 or 2. So 100% of patients had stage 1 or 2. Those that were not screened, only 45% of patients who developed a cancer had an early cancer. Stage 3 to 4, screened patients, 0 had an advanced cancer compared to 55% of patients that declined screening. And so those 3 to 4, that's where you're talking chemotherapy, other surgeries, and potentially missing cancer cures. The rate of colorectal cancer death was 0 in screened patients versus 7.6% in non-screened. And 5-year colorectal cancer of patients that had it was 100% in screened patients versus 54% in those are not screened. And so although screening is not pleasant, it prevents colorectal cancer. If you do get a cancer, it's going to be at an earlier stage, and the risk of colorectal cancer death is negligible. So 2/3 of colorectal cancers in Lynch are proximal or upstream of the splenic flexure, so they're more on the right side, which is why we have to do colonoscopy instead of just flexible sigmoidoscopy for screening. And the polyp to cancer progression happens faster in Lynch syndrome, which is why we have to screen so frequently. So colorectal surgery, the type of surgery that's done if a cancer is found or a large flat polyp that can't be removed endoscopically is found. Those are the only times we do surgery. So we don't prophylactically take out the colon in Lynch syndrome just because you've got the genetic defect. Because even for the worst defects, worst genetic defects, you still have 50% chance that you're never going to get a cancer. And so we only do cancer if there's a large polyp or a flat polyp that can't be removed endoscopically, or if there's a cancer. Now, the type of surgery, if you had a cancer that just was a cancer not associated with Lynch, we usually will do what's called a segmental resection. However, for Lynch, we usually will take out about 75% of the colon, and then we do a hookup between the small bowel and the sigmoid. So we leave about 1/4 of the colon in place. And the reason, I'll just talk about the reason we do that. The only place we don't do that is in rectal cancers. If you take out all of the colon plus rectum, the functional results are not very good. And so for rectal cancers, we'll usually just take out the rectum and hook up the descending colon to the anus. So why do such a big operation in Lynch compared to others? Well, the risk of developing a second colorectal cancer in a segmental resection versus extended resection is pretty high. So if you just take out a part of the colon, up to 35% of people will have a second cancer within 10 years. Compared to if you take out most of the colon, this 15% is much higher than all of the other numbers. And so it's really a balance. You want to look at the morbidity of the surgery, quality of life and bowel functioning, versus the risk of developing a cancer down the road and having to have more surgery and maybe having problems related to metastases from that cancer. And so most guidelines recommend colectomy and ileorectal or ileosigmoid anastomosis as the preferred treatment of Lynch with either a cancer or neoplasia that's not controllable by endoscopy. The only time we just take out a portion is if there's something about that patient that we think they're not going to do well with ileorectal. So with an ileorectal, most patients will have, say, 3 or 4 bowel movements a day, have excellent control. Patients often get down to 1 to 2 bowel movements a day over time. And so really there's not a huge impact on quality of life. Some patients though, like if they have underlying sphincter problems, other issues, we know that they're not going to do well with an ileorectal. And so there you might sort of decide to do the segmental resection, accepting the fact that you're going to have more trouble with surveillance and a higher risk of developing a second cancer. Upper endoscopy, there's no clear data to support surveillance. We'll usually recommend a baseline upper GI scope to check and treat for a type of bacterial infection in the stomach that can predispose to develop gastric cancer. And those patients that have a family history of gastric cancer or of Asian descent who are higher risk of developing cancer in the stomach, every 3 to 5 years do an esophageal gastroduodenoscopy. Other guidelines, similar. So our surgical team, there's myself. I'm, as Dr. Cohen liked to point out, the senior old surgeon on the team, Anthony DeBuck, Montage Brar, and Aaron Kennedy. And there's also one of the gastroenterologists, Dr. Jaya Lingam, who the genetic counselors can refer to. I'm going to, because I'm talking too long, I'm going to click over these two and just talk a little bit about bowel preparation. And that's because having had colonoscopies myself, I know the bowel preparation is the worst part of the colonoscopy. And everybody always looks for an easy bowel prep, but to get a good colonoscopy, to take out small polyps, what you really need is a good bowel prep. And so there's not much point coming and doing a colonoscopy and not having a good bowel prep. So preparation can be inadequate in up to 25% of examinations. And if you look at suboptimal bowel prep, it's associated with higher risk of complications during the procedure, an increased overall procedure time. You have to come back sooner if you have a poor quality colonoscopy. The cecum, the right side of the colon, is where many of the cancers occur, and we're more likely to miss cancers if you have a poor prep. And there's a much higher risk of missing adenomas, so not taking out a polyp because you don't see it. So ideally, a bowel preparation should be safe, efficient, and well tolerated, and should allow you to detect polyps that are more than 5 millimeters in size. This is just how we rate them. And you can see that if you have a high quality bowel preparation, you're much more likely to find polyps. So what bowel preparations work well? I'm going with the bipegalite these days. I don't know. People here are probably pretty used to bowel preps. The 4-liter PEG solution is an awful solution to take. It's hard to drink. It's hard to choke it down. The 2-liter, I find it's a pretty reasonable prep. It's much easier to take than the 4-liter. And the other one is the Picosalax. That one is fine as well to take. I have to say that the 2-liter bipegalite probably gives less cramping than the Picosalax. Picosalax is much lower volume that you have to drink. There are rare serious negative outcomes. I haven't seen them in 30 years of doing scopes. And adequate hydration. So when you're doing a bowel prep, make sure you're drinking a lot of clear fluids, because it really, first of all, minimizes the side effects of the prep, but also improves the quality of the prep. So we now use what's called split dosing, where you take some of the prep the night before, and sometimes if you have, especially if you have an afternoon scope, you'll take the other half in the morning. Varies against split dose bowel preparation. Obviously, if you're traveling on the 401, you don't want to take a prep just before you get onto the 401. Females tend to not take the split dose prep for whatever reason, as well as males. Okay, so since I'm out of time and Zane said I had to stay on time, I'm going to quit there, but I can talk about sedation if anybody has any questions about that. Thank you very much.
Thank you so much, Helen.
Thank you, Helen, very much. I think Melissa's going to handle some of the chat questions now.
Yeah, actually, some people wanted you just to quickly go back and review aspirin and starch, if you don't mind for just a minute to do that. Especially aspirin, I think people are curious about.
Okay, so resistant starch. This was a study, cancer prevention with resistant starch in Lynch syndrome patients, 10-year follow-up, taking 30 grams of resistant starch powder daily for an average of 2 years showed a reduction of non-colorectal upper GI cancers. And it's a relatively easy thing to do. Uncooked oats, overnight oats, bananas, beans, green peas, lentils, pearl barley, like all of the things that you know you're supposed to do. The idea is that you get a better gut biome. And so you get the better bacteria developing in the gut. I have to say that the benefit is not huge, but it doesn't hurt to do it. In terms of aspirin, this was a study done in Lancet, which was a pretty high dose. Most people would probably take a much smaller dose. Most people now would probably take like a baby aspirin, but taking 600 milligrams a day for at least 2 years showed a 50% reduction in Lynch syndrome-related cancers. The reducing effects started after 5 years. So for every 25 patients with Lynch treated with 600 milligrams of aspirin, 1 cancer is prevented over approximately 15 years. Like that's, again, it's a lot of aspirin to take for a long time, especially the 600 milligram dose, because I think that at that type of dose, you're probably at risk of developing upper GI symptoms if you're taking 600 milligrams of aspirin. I don't think it hurts to take a baby aspirin a day, but I have to say that personally, I don't recommend patients take the aspirin daily. I don't know what the genetic counselors are telling patients, but it seems like a lot of aspirin.
Yeah, they're currently doing the follow-up study to this one with Dr. Byrne to look at baby aspirin. So in general, the thought is people should consider taking 81 milligrams, which is baby aspirin daily. We don't know for sure that it will be effective. That it takes a long time. You have to take the aspirin for 2 years, and then it takes 5 years to see the risk reduction. So it's a long process to get the answer, but we don't recommend anyone take it unless they speak to their doctor, because of course there are side effects with taking it.
So the baby aspirin is less likely to cause problems, like 600 milligrams, which is where the evidence is a high dose. Baby aspirin probably is going to show similar effects and is less likely to cause problems. But you have to remember to stop your aspirin a week before you come for your colonoscopy.
So there are tons of questions, so many. So I'll just start getting to a few. Someone's asking, does the time when you have to do your colonoscopy go up as you get closer to 60 and older? So they know you should start early, but what happens when you get older?
So you still should have a colonoscopy every 1 to 2 years. And as you get older, you're probably more likely to develop something, especially if you have the higher risk variants. And so you shouldn't forget about the colonoscopies. We generally stop doing surveillance at around 80, because then the risk benefit starts to, your risk of having complications from the colonoscopy starts to increase, both from the sedation, the preparation, and the colonoscopy. And so the risk benefit starts to shift a little bit away from surveillance.
So a lot of patients actually are asking about sedation. Why can't they just put you right out for a colonoscopy?
So at some places they do, they give you propofol. Propofol is not a general anesthetic, so sometimes people will still wake up a little bit during the colonoscopy, especially if you're extremely sensitive. So the downside of putting you out completely is if you find a polyp, like it often is quite helpful to be able to manipulate the patient, to put you on your back, to put you over on your side. And in fact, many of the recent recommendations and the way that we're training people to do colonoscopies now, we avoid putting people completely asleep because it's a lot harder to do that and not as safe. If you're having propofol, but you do get a better opportunity to see the whole colon if you can move the patient around in the bed. If you have any liquid left over, you can end up moving liquid around. But also if you're having trouble getting around corners, moving the patient can make it easier to get around the colon. So then finally, propofol just isn't available everywhere.
Somebody was asking about doing PET scans or CAT scans. We get that a lot. Why can't they just do that instead of a colonoscopy?
So CAT scans are a fair amount of radiation, but also with scans, you find big cancers. What we want to find is little polyps that we can take out with the scope, and then we don't have to operate on you. You know, if you're doing, you can sometimes see 2 or 3 centimeter polyps with CAT scans. PET scans are only for cancers.
Someone's asking about probiotics. Do you think probiotics is helpful to keep the gut healthy?
Keeping a good, healthy gut biome is, I think, we're recognizing is more and more important. And most probiotics that you take over the counter probably don't do as much as you think they do. So as long as they're not too expensive and patients want to take them, I say fine. You know, but many of the ones that come in pill form, you're probably taking mostly dead bacteria as opposed to bacteria that are actually really going to help your gut. I think that it's the whole idea of the starch is that you want to eat foods that are good for promoting good gut bacteria.
A lot of people are saying that they would like to watch this on a recording, so I'm just going to mention that we are recording this and hope to post it on our Zane Cohen Centre website, and we will send an email to everyone when that's up and running. So that answers that question. People were also asking about inflammation in the colon and gastritis and how that might impact. Some of our patients have IBD, so how does that impact the screening if they have inflammation in their gut?
So inflammation, like if you have IBD, having chronic inflammation in the colon increases your risk of developing colorectal cancer as well. And it also can make it more difficult to see polyps. And so you probably don't get as good a screening. So somebody who has a lot of inflammation in the gut, so ulcerative colitis or Crohn's, likely should be sticking more to the every 1 year screening as opposed to stretching it out to the 2 year, because at higher risk of developing cancer. And you're also at higher risk of things being missed at endoscopy. Mild gastritis, if you have Helicobacter, it should be treated.
So yeah, we talk about that with the patients, that H. pylori, bacteria that lives in a lot of people's stomachs. We don't even know it's there, but it is a risk factor for gastric cancer. So yeah, we agree. It should help people out.
And it's often found in patients where you see gastritis. So the reasons you get gastritis, Helicobacter or taking non-steroidals, those are the things you sort of see patients have gastritis.
Some of the patients are wondering about what gene they might have. Can you tell that by colonoscopy, what gene they carry, or how would you suggest they find that out?
I would suggest they see you to find it. A colonoscopy, to be honest, most Lynch syndrome, most of the time when we're doing colonoscopy for patients with Lynch, what we see is a perfectly normal, beautiful colon. Like, I would say that of the screening colonoscopies I do, I mean, people, especially the first one, quite come in and they're quite anxious, but most of the time, you don't find that much. I mean, that's what we want, right? We want to find not that much. We want to find tiny polyps or nothing. And that's usually all we find. And so whatever gene you have, I'm not going to see it at colonoscopy. I'm most likely going to see a nice normal looking colon.
Yeah, we would say the same. Ask your genetic counselor. And some people ask about EpCAM. EpCAM always follows the MSH2 gene. So they were asking about it on the diagram, and usually those two go together. MSH2, EpCAM actually impacts MSH2. That's how it causes Lynch syndrome. So it follows a lot of the risk of MSH2. Somebody was asking about fecal transplant. Any thoughts about fecal transplant?
So fecal transplant has been used for colitis, but you know, when you've got a nice normal Lynch colon, there's really no point doing a fecal transplant. But the idea of fecal transplant is just to get the good bacteria in there. But there's no reason to think you don't have good bacteria in there if you're eating well and you know, not taking lots of it. So it has been used for colitis with some evidence of benefit. It's hard to get access to it, but for somebody with Lynch, it's not going to change the fact that you still have a predisposition to developing colorectal cancer.
Someone was saying, what if they can't tolerate the big 4-liter prep? Can they ask for another prep that is frowned upon, like maybe Picosalax?
Yeah. Like I have to say, I don't care. As long as you come to me with a clean colon, I don't care what prep you take. I think a lot of people prefer Picosalax. I think I could tell you that if someone told me to take the 4-liter peg, I wouldn't do it. I'd just pretend I did and do the 2-liter actually is not bad. I've had the Pico, I've had the 2-liter, and the 2-liter one, the BiPeg Light, is actually not that bad to take. The 4-liter, no way I'd do it. There are a few patients though that should do the 4-liter, like if you've got renal disease, you know, if you're at really high risk of complications of the prep, those are the patients that should take the 4-liter prep. But for most healthy patients that are coming for screening for Lynch, Pico, BiPeg Light, whatever you want.
Someone was saying after they have, let's say they have colon surgery because of a colorectal cancer, but they didn't have a full subtotal, they just had a partial. Do you recommend they go back and have more extensive surgery, or that they just continue with colonoscopy until another lesion is found?
I would recommend, like, we don't do prophylactic. So once you've had the surgery, then you may as well just wait and see if you need more surgery or not. I don't think that you have to prophylactically have more of the colon removed. But you just have to remember that even though you've had part of your colon removed, you're still at high risk of developing a second cancer. And so you should continue with the every 1 to 2 year screening. I mean,
Well,
even if you had a subtotal with ileosigmoid, you still have to continue with screening. But it's a lot easier to screen because we're now just going this far instead of this far.
You know, I was thinking that patients are going to take your recording saying you would never take 4 liters and show it to their gastroenterologist.
Uh-oh, maybe you could edit that out of the recording.
Right. So there's a question about someone who has colitis, and we have really a world-class IBD group, starting with Dr. Cohen and Dr. MacRae and a lot of the people that we have. So I thought you might be able to answer this. So someone mentioned that they had an IRA, which is for the patients. It's a surgery that removes almost all the colon except for the rectum. And they're taking Pentasa for colitis. Well, this performs similar to aspirin. They also said their GI suggested an immunosuppressant, but they worry that the colitis or their meds might be protective given the immune response to Lynch syndrome. So they're worried about taking an immune suppressant when we know the immune system might be able to fight cancer and Lynch syndrome. So any thoughts on that?
So if you have colitis and Lynch, the most important thing is probably to get into as deep a remission as possible, that the ongoing inflammation in colitis predisposes you to developing cancers, and Lynch predisposes you to developing cancers. And so if the Pentasa is keeping Pentasa, and being on medications like Pentasa probably decreases the risk of colorectal cancer in inflammatory bowel disease by keeping you in remission. So if the Pentasa is keeping you in remission, then I mean, I can't say why your gastroenterologist said that you maybe should be on another medication, but it might be that they're still seeing inflammation there.
Some people were wondering why aspirin can reduce the risk of colon cancer, and if that happens in the general population as well as Lynch syndrome. What's so great about aspirin?
I'm not 100% sure. It seems to be great for a lot of things.
Stroke, heart, yeah. I think they call it a COX-2 inhibitor. So it likely works on reducing inflammation, is my understanding. And so there's a mechanism in it that likely reduces it. And they did do a big aspirin trial in the general population among nurses, right? And I think it actually did prevent or reduce the risk of colon cancer.
Yeah, it did decrease the risk of colon cancer.
Mm-hmm. Even in the general population.
I have to say, I take a baby aspirin a day. But you know, it doesn't hurt.
Yeah. Zane,
Except
any thoughts on that?
Don't forget to stop it before your colonoscopy.
Yeah.
Because if you have a polyp and you come with and you're on aspirin, we can't take out the polyp.
Dr. Cohen, any thoughts about aspirin?
Well, I think I agree with Helen. I think right now, I think the best thing to say is that we just don't know. We're waiting for the results of aspirin and colon cancer in general, and in Lynch in particular. So I wouldn't right now. I think I got the same impression from Helen. I wouldn't right now be an advocate for taking aspirin.
Some patients are asking about diverticulitis and how that could impact their risk or screening.
So with diverticulitis, so if you have a lot of diverticuli in your sigmoid colon, that's usually where they have it, and that tends to be age-related. It makes it harder to do the screening, so it's harder to get through. And with diverticular disease, you get the folds get sort of thicker, and the colon is sort of pushed together a little bit more. So it's easier to miss cancers or polyps in patients with bad diverticular disease. And so that's diverticulitis doesn't impact your risk of developing cancer. It's not like ongoing inflammation like you see in inflammatory bowel disease. So it doesn't increase your risk at all, but it just makes it harder to do the colonoscopy, higher risk of complications of the colonoscopy, and is missing something in the diverticular segment.
Yeah, we're going to try and review the questions that genetic counselors will. You can reach out to your genetic counselors if we didn't get to it, but I'm going to turn this back to Dr. Cohen to end this session and introduce the next one. Thank you.
Thanks very much, Helen, and thanks, Melissa, and thanks for all the questions. We'll try to get back to the questions and try to answer all of the questions, but right now we have to go on. And the next speaker is going to be Dr. Raymond Kim, who's an associate professor in the Department of Medicine. And Raymond is really one of the leaders in cancer research, particularly in the Ontario Institute for Cancer Research. And he's head of the Ontario Genetics Program. His research focuses on genetic technology to help with patient care for hereditary cancer syndromes. And he's going to talk about genetics, and his talk is entitled Genomic-Driven Advances in Lynch Syndrome. So if you're there, Raymond, please take it away.
Can everyone see my slides? I think we're good. So thank you again for inviting me today to reconnect with all of you, the patients, and who we do our research for. And I'm actually very grateful, as a lot of you are participants in the research that we are doing, and I'm going to share some of that today. So this is a little bit of an outline. I'm going to introduce the Ontario Hereditary Cancer Research Network, which is learning a lot from the Familial GI Cancer Registry, started at Mount Sinai. We'll talk a little bit about precision medicines and Lynch syndrome, talk about some cancer vaccines, and cell-free DNA and liquid biopsy study that we are doing on Lynch syndrome patients. So as Zane mentioned, I lead the Ontario Hereditary Cancer Research Network, and this is a collaboration with the OICR. So the OICR is the Ontario Institute for Cancer Research and is across the street on University Avenue at University and College, and is a cancer research institute that got interested in hereditary cancer largely because of the excellent work that has been coming out of the Zane Cohen Centre. And we are delighted that they are collaborators with us here. So what, everybody knows that hereditary cancer is quite important, but there has been a lot of advances in the understanding of hereditary cancer. So this is a diagram that I put up that patients, when they are diagnosed with a gene mutation and don't have cancer, are called previvors in the lay press. They undergo intensive surveillance with endoscopy and imaging if necessary. Sometimes they invariably develop cancer and become a cancer patient. They get precision cancer medicines based on their gene mutation and become a cancer survivor. But because they are born with a genetic change somewhere else in the body, they develop a cancer, such as colon cancer, endometrial cancer, or brain cancer, and Lynch syndrome. So this cycle continues. But the reason that these patients are so important is that they actually inform us about all cancer and how they are actually driven. So in Ontario, there are about 19 specialized cancer clinics that see patients who have Lynch syndrome and other hereditary forms of cancer. Recently, as of 2021, we used to have to send some gene panels out of country, and Lynch syndrome, of course, was done at Mount Sinai. But as we expanded genetic testing, we incorporated more labs in Ontario. So irrespective of where you live in Ontario, we hope to have increased genetic testing access for patients who have an inherited syndrome. However, challenges still exist that carriers are difficult to ascertain and track, patients have inequitable access to research, and there's lack of standardization and data sharing challenges. So this is where we tried to get the Ontario Institute for Cancer Research involved, and they created a Ontario Hereditary Cancer Research Network. And we asked a lot of the patients, including members of this audience, on if you were, what would be helpful for you or your family member who has inherited a gene mutation at an increased risk of developing a cancer. And a lot of individuals say they would like increased cancer screening, access to experts and coordinated care, patient support and advocacy, precision medicine and clinical trials, access to preventative surgical options, and testing family members, and discussing reproductive options for family planning patients. So the Ontario Institute for Cancer Research funded a $4.5 million grant that is looking at all types of hereditary cancer patients across Ontario. And the idea was to identify all patients who are carriers in Ontario, engage the community and develop a database, and populate the database and develop surveillance guidelines, and enable genomics and gene discovery for hereditary cancer patients. So this is actually probably happening very actively in the Zane Cohen Centre for Lynch syndrome, and other kind of boutique operations throughout the province, such as BRCA with Stephen Narod's group at Women's College, and Irene Androulis at the Ontario Familial Breast Cancer Registry. And there's another pediatric cancer genetics program at the Hospital for Sick Children. However, these are very Toronto-centric, and lots of people across the province may not have access to this, depending on where they are tested. So we developed a committee that kind of helped us decide how to interact with these initiatives and build a provincial-wide hereditary cancer research network that includes Lynch syndrome patients and other hereditary cancer patients to really galvanize and leverage all of the patients that are so valuable in understanding the pathogenesis of cancer. So we have 3 committees. Many of the members of the Zane Cohen Centre participate in it and lead these committees. This includes a data management subcommittee, a laboratory subcommittee, and a research and ethics subcommittee. And some of the audience here are actually patient partners, because patient partners are important in understanding the priorities for these research questions. So what questions could we ask with this type of province-wide registry? Simple questions such as, how many people in Ontario have an MLH1 variant? What is the incidence of ovarian cancer in PMS2 carriers? By what age do patients have risk-reducing gynae surgery in Ontario, and do they actually have it if you have Lynch syndrome? And how many people in Ontario with my variant have had a colonoscopy every 2 years? Or are they actually not getting a colonoscopy? So we also hope to connect patients with researchers and clinical trials as we build this registry. And there'll be different tiers of access, and we hope to have aggregate data that patients will be able to view and the public will be able to view, an approved researcher portal where we'll have anonymized data, linked data, and some really refined patient data where we will have access to actual patient level data such as pathology, age, personal health information, so we can access clinical trials. I wanted to shift gears a little bit. That was the Ontario Hereditary Cancer Research Network. And why are we doing this? Is because patients who have Lynch syndrome and other hereditary cancer disorders are very hard to collect, and doing clinical trials and research on them is a little bit difficult in a large province such as Ontario. And this is important because therapies for hereditary carriers are actually happening. We have BRCA patients, that's the Angelina Jolie gene, have access to PARP inhibitors. Hereditary kidney cancer, such as von Hippel-Lindau, have a precision cancer medicine known as belzutifan. And importantly, for Lynch syndrome, immunotherapy, in addition to aspirin, is a precision cancer medicine therapy. And I wanted to discuss what, in fact, immunotherapy is. So immunotherapy is really capitalizing on the immune system. So the immune system is built to recognize foreign entities in the body. This could be a virus if you're infected by something, or it could be also cancer cells. Now, how cancer cells are viewed as foreign by the immune system differs depending on the type of cancer. Now, in Lynch syndrome, we have something that is called mismatch repair. So mismatch repair is a problem with the DNA repair mechanism that the cell uses. So the DNA, which encodes all the proteins in your body, is constantly getting damaged, and the cell has ways to repair it. In Lynch syndrome, it doesn't repair it properly. So the genes are being constantly changed and mutated in the body, and that's what actually causes cancer. In patients who have Lynch syndrome, they have all these foreign types of proteins being made because in the body, the cell's DNA has been changed, resulting in proteins, which are the action items of the genetic material, to be abnormal. It's as if a virus or some sort of other type of foreign body is infecting the cell. And they have an immune mechanism by telling the cell has a mechanism by telling the immune system that I am infected or I have genetic changes that are making me unusual. So please eliminate me because I'm a bad cell. Now in Lynch syndrome, we have this because of the mismatch repair deficiency. That is the fundamental problem that results in all of these abnormal proteins. And what Lynch syndrome cancer cells have actually developed is a way to tell the immune system that, go by me. I'm actually not an unusual cell. I'm going to disguise myself as a normal cell, even though I'm a bad cancer cell, because I'm going to put up something that's called PD-1 ligand. So PD-1 ligand is a way to say to the immune system, don't worry about me. Even though I have these genetic changes, I'm actually fine. So what the immunotherapy actually does is breaks that decoy that the cancer cell has put up. So the Lynch syndrome cancer cell has PD-1 ligand that is overexpressed, telling the immune system to go by it. But if you remove that decoy, then the immune system is primed and sees, okay, this is a Lynch syndrome cancer cell that has all these screwed up proteins that are being expressed on the surface, so I'm going to go ahead and kill it. So that's how immunotherapy works in patients who have Lynch syndrome, and that's why it's exquisitely sensitive when patients who have Lynch syndrome get this therapy and can be life-saving. So that's the fundamental biology behind Lynch syndrome and how immunotherapy actually works. So that's where the precision cancer medicine piece falls through. Now, this ties in very closely with a vaccine. So I use this analogy of a cancer cell being similar to an infected cell with, an antivirus. And the most famous virus these days is COVID. And we get a vaccine for COVID. So when we get infected by COVID, the cells that are infected by COVID have immune cells that are ready and will attack it. A similar system we can use to think about cancer. If we design cancer vaccines that develop immune cells that are primed to attack cancer cells, maybe we can prevent cancer or prevent it from progressing very rapidly. So this is where the term cancer vaccines come from. Now, how do cancer vaccines, and are they being designed in Lynch syndrome? So getting back to the fundamental biology problem of Lynch syndrome is that they develop a lot of, messed up proteins. And these messed up proteins can be expressed on the cell. So if we develop vaccines against these messed up proteins, then perhaps we can develop an effective vaccine. So that's how the vaccines against Lynch syndromes are being currently engineered, by creating a number of different neoantigens. These are these ways of expressing things. So we can develop these vaccines and inject people with different types of modalities to prime the immune system. And this is just a pictorial representation of this, and I'll skip this in the interest of time. So I wanted to shift gears a little bit and discuss, in addition to cancer vaccines, which potentially can prevent or augment the immune system from attacking Lynch syndrome cancer cells, in addition to immunotherapy, helping patients who have Lynch syndrome-related cancers. My main interest is looking at how we can detect cancer early in patients who have Lynch syndrome. So this is the diagram that I described before, and this is the basic life cycle of patients who have Lynch syndrome. You're born with a genetic change, you undergo surveillance, sometimes you get a cancer, and then you get the treatment, and etc. But we really don't know how to differentiate where you are on the cycle. You could be very close to being cancer-free, or you could be very close to actually having a cancer. How can we differentiate and detect cancer early in addition to the endoscopy? And not all cancers in Lynch syndrome are being detected by the current surveillance protocols. So this is where the concept of cell-free DNA comes in. So what is cell-free DNA? So cell-free DNA is DNA that's floating around the plasma or in your blood. The plasma is the clear portion of your blood when you let it settle. The red cells are at the bottom, the white cells are in the middle. They fight infection and contain the immune cells, and the plasma floats to the top. They contain clotting factors, and now we recognize bits of DNA that are shed from cells that die within the body. So cells that die within the body can be from normal cells which turn over. It can be from cells that are undergoing inflammation, but it can be cells that are dying because they're cancerous, and cancer cells grow very quickly and die very quickly, and that's what a tumor is. So what we're interested in is, can cell-free DNA be used to see where you are in the trajectory of becoming a cancer patient? Do you have cancers brewing somewhere in the body and your cell-free DNA signal is high, or are you very low in your cell-free DNA burden? So there's various different ways that you can analyze cell-free DNA. For those technical people in the crowd, it can be shallow whole genome, methylation, a targeted panel, etc. But in general, you're looking at the bits of DNA that are floating around in the blood that are released from those cancerous cells that have died and turning over. So we have a network known as CHARM, which is cell-free DNA in hereditary and high-risk malignancies. We had a CIHR grant that funded this, and we are doing a lot of test development to see if we can design a test specifically for Lynch syndrome patients to detect cancer early. And we've had over 3,000 samples collected, 700 collected from Lynch syndrome patients, and many of you from the Zane Cohen Centre and the FGICR. So I'm grateful for your contribution. And this is a pan-Canadian effort that spans from the east to the west, from Eastern Health to BC Cancer, and we have a lot of partners that are helping us do this. And this is the website, charmconsortium.ca. So initial preliminary data we can show here for people who are interested in data, and that here we have a patient number 224, who is a cancer-free patient. And you can see the cell-free DNA copy number, which is a certain type of genetic change, is rather quiet. And then we have a patient who's a patient 310, who is a patient who has active cancer at Mount Sinai with colorectal cancer. And you can see the cell-free DNA signal is much more noisy. So we're thinking that, in between this process, the copy numbers or the genetic changes that we are detecting in the cell-free DNA will tell us, is this patient really cancer-free, or are they progressing towards a cancer and we should be a little bit more concerned about them and perhaps be a little bit more proactive in their surveillance? So we're hoping with this cell-free DNA technology, it's also called a liquid biopsy if you see it in the lay press, it will be able to tell us, and we should be able to tell with a blood test, that where a patient sits if they have Lynch syndrome, if they are relatively cancer-free, or if they're progressing to cancer, and we should be a little bit more vigilant in their symptoms and perhaps order additional testing such as scans or other endoscopy, et cetera, or blood tests. So on a final note, in addition to the data that I have shown with Lynch syndrome, we were recently funded by the Canadian Cancer Society to do a prospective trial on this type of liquid biopsy cell-free DNA technology. So we will be looking for more patients to do this, because initially we did it in a retrospective test development approach, and now we actually want to incorporate it into the clinical practice of our providers to determine whether or not it's actually that useful. So with that, I will show up my last slide, and I hope I was able to demonstrate a little bit about the Ontario Hereditary Cancer Research Network, which is a province-wide registry for carriers, discuss a little bit about precision medicine in patients who have Lynch syndromes, talk about cancer vaccines, and the really use of cell-free DNA and liquid biopsy for patients who have inherited cancer predisposition. With that, I will stop.
Thanks, Dr. Kim. Zane, I'm not sure if you wanted to say anything. I was going to moderate some questions for Dr. Kim. There are a couple of good ones that have already come up in the chat. Zane, did you want to add anything before we start this section? Okay, we can get started. The first question is a good one. Someone was asking, how would immunotherapy affect a patient who also has an autoimmune disorder? Is there any research in this area?
That's a very good question and a little bit out of my scope because I don't prescribe either. But it would be interesting to see if there are patients, because my understanding with immunosuppressants, they work on a different mechanism of the immune system to decrease inflammation, versus immunotherapy works on a different T cells versus B cells versus inflammation, etc. So I know there's often crosstalk between the gastroenterologist and the rheumatologist that prescribe the immunosuppressants versus the oncologists who provide the immunotherapy. But I'm not aware of any cases that have come to my attention cross-talking the two, but they do act on different avenues, and probably immunosuppressing somebody too much is probably not a good thing from my understanding.
Another question was, is immunotherapy considered a primary standard of care for any Lynch syndrome related cancer, or is it still mostly on a trial basis?
I think it's pretty much standard of care. It may be through a clinical trial in some situations, depending on the type of cancer, but Kara, I know we send patients very frequently for immunotherapy, and they do get it fairly readily. Things have changed quite remarkably in the past couple of years since those landmark papers came out.
And I understand it's approved for certain primary cancers, gastric, I believe. Melissa, maybe correct me if I'm wrong, but so it is a primary clinical treatment for a subset of cancers, and of course every case is a little bit different. So it would be a question for your oncologist, but always good to know if you have Lynch syndrome and you have a cancer diagnosis, I guess, to see if the testing's been done on the tumor to see if that is in fact, if it was caused by the mutation or a cancer for some other reason as well. So I had a question. I think people are wondering, will be wondering who might be eligible for the prospective CHARM study. Will it be some of the patients who'd already consented, or will be recruiting new patients? We have a good audience here, people who might be interested.
Yeah. When we go back in person and we do Lynch syndrome night again, I'm hoping to do a kind of recruitment blitz for the audience here. The people who are enrolled in the previous cell-free DNA study will have to be consented again. We're trying to figure out the logistics of rolling them into the prospective trial, because the prospective trial, the stakes are a little bit higher. It's going to be returned to you, and we'll make medical management decisions based on that. But anybody with Lynch syndrome who isn't going, we're trying to figure out the inclusion criteria, but probably shouldn't have an active cancer being treated, because that's going to affect the cell-free DNA signal and is really going to be a little bit difficult for us to insert that into their cancer treatment. And really, to be quite honest, they should be focusing on their cancer treatment for the time being. So my sense is, given my experience in liquid biopsy trials, it'll be patients who have never had a cancer or have survived a cancer. And usually that's about 3 years out from their most recent cancer.
Okay. So perhaps when you're ready to recruit for the next phase, we'll be sending out a message to people who could be eligible. Someone did ask, how do we get tested with liquid biopsy? But I think to clarify that it is a research basis at this point. So by joining the trial, perhaps in future and there may be results given back, it sounds like, for the next phase. So
yeah, and just for people who will start looking this up and Googling, there are many different, I put up a slide, there are many different types of liquid biopsy that are out there. The one that we're trying to design under the CHARM project is specifically geared toward Lynch syndrome patients. So it makes it a little bit, that's why I think it's it's a little bit different than the other ones that are hunting for different types of cancers.
Okay. Someone asked if there are examples of liquid biopsy results on cancer survivors and what their cell-free DNA levels look like.
Yeah, so we're working on that actively, and we want to have that wrapped up before we start launching the trial. I don't want to make any promises, but our goal is to open this up in January. The main of 2024. The main barrier is going to be us getting ethics approval, contracts between all the sites because it's a prospective study. But to get back to the point of the cancer survivors, what we are seeing in other studies in other genes is it looks similar to patients who have never had cancer before. But we're still trying to figure out all of that with the 700 samples that we have from all of you. So more to come, and I'll be happy to provide an update at the next night.
Jumping back to immunotherapy, someone was asking, how long does it keep working? Not sure.
Yeah, so that's another question for an oncologist who prescribes the immunotherapy. But my understanding is it's a time-limited course, just like most chemotherapeutic regimens. And if I were to hypothesize, is once the cancer is cleared and you're in remission, the utility of the immunotherapy becomes a lot less. So my experience in working with some of these and seeing some of these patients is that the immunotherapy is given and then it is stopped based on the recommendations. And as long as the scans are clear and the patient is in clinical remission, then it's no longer utilized. Now, the interesting thing is how long do the effects of immunotherapy keep persisting? I could hypothesize that if immunotherapy was given, you're going to actually have an immune system that is primed to kind of attack your subsequent cancer. I don't think that data is out there. It'd be certainly interesting because you could hypothesize and say that people who've received immunotherapy probably are at decreased risk of getting their subsequent cancer because they've developed an immune response to their original tumor. But that's all me kind of using my scientific hypothesis. But in that regard, potentially it may work for a long time, but don't hold me to that.
Lots to think about. A few people have asked sort of how to get or what is a liquid biopsy. Just to clarify, it is looked at through blood work. And I understand you do serial blood draws over time as part of this study, but to clarify for people what that means.
Yeah, so a liquid biopsy, we use that terminology because a biopsy is when you go in with a needle and take something out to examine the genetic material within the tumor. In a liquid biopsy, we actually just draw blood. Usually it's about 30 milliliters and 3 different tubes. It's a specialized tube that preserves the cell-free DNA. And then the reason they call it a liquid biopsy is because it examines the DNA that is released from the tumor cells. But essentially exactly what you said, Kira. It is a blood test. We used to draw it annually, and in the trial, we're probably going to draw it 3 times a year.
Okay. Another question I had was just going back to the possibility of a vaccine that you mentioned. People do ask us about that and how much of a reality that is, or what a timeline might be for something like that.
Okay, so I really wanted a vaccine for Lynch syndrome patients to come to Toronto. I went as far as meeting Moderna, trying to convince them, but then they got distracted by a different portfolio in oncology. So I'm still working on it. I would love for our group to have access to a cancer vaccine. I do think it's going to be a reality quite soon because of the technology of mRNA vaccines. You can be so nimble and you can create so many epitopes and T cells based on that. Now, when it's going to come to Lynch syndrome, that's my homework to do, and this and in partnership with the Zane Cohen Centre. But I would like it to come to Toronto at some point very soon.
Okay. A few people. This is a bit off topic, but a genetics question. People wondering about CRISPR and its sort of potential application to Lynch syndrome.
Yeah, so CRISPR is a very interesting thing. So for people who do not know what CRISPR is, so CRISPR is basically a bacterial type of technology that goes into the cell, cuts out a piece of DNA, and then replaces it with a different piece of DNA by using a guide DNA signal. Now, CRISPR has a lot of use, but the problem in Lynch syndrome patients is that we can't deliver CRISPR to the entire body. So if we wanted to alter and change the genes in an individual, that would be rather difficult. Some people are using CRISPR as gene therapy, and gene therapy is going into a cell, altering it in a certain way, and then leaving that cell. But the main issue is access to those cells, and the cells that are most accessible are blood cells, respiratory cells. Colorectal cells are difficult to access, and same with endometrial cells. So you can imagine you'd have to have a massive way to deliver all these CRISPR vectors to change the DNA inside of patients with Lynch syndrome. Probably the biggest application I could see for CRISPR technology is using it as gene therapy for certain types of cancers that are related to Lynch syndrome and altering the DNA inside of there to repair it and prevent it from being too aggressive. But the problem a lot of the times that we find in cancer in general is that the train has left the station, and there's so many mutations that are happening in the cell. It's hard to bring that train back. So I'm not, as opposed to the other technologies that I described today, I'm less optimistic about CRISPR in cancer patients per se, but it doesn't mean that it's not a potential option.
I like the train leaving the station analogy. That's useful. I think that's most of the questions. Someone else asked again about receiving immunotherapy or if chemo has to be done first. And I do believe it depends on the site of the cancer and whether the tumor's been tested to show that it's immunodeficient, and as well the nature of the clinical trial at any given oncology center. So that would be, again, a good question for an oncologist if you have Lynch syndrome and you're diagnosed with cancer, just to inquire. It's important for your oncologist to know about. And then just briefly, I think that was all the specific questions, Raymond, for you. Thank you so much. I'm just going to circle back. We keep getting a few questions, sort of more general ones with regards to insurance discrimination or what mutation. People want to know what mutation or what gene their mutation is in, or what age to test their kids for Lynch syndrome, things like that. Those are questions that feel free to circle back to your genetic counselor to ask us those questions offline. We'd be happy to help you with those things. So, thanks again, Dr. Kim, and Zane, I will pass it back to you.
Okay, thanks very much, and thanks, Raymond. I'm very excited. I'm glad you mentioned the vaccines, because I'm very excited. mRNA platform seems to be good for everything. So maybe you could comment a little bit on that, more on that as well in detail.
Yeah, so the mRNA vaccines are what they're actually trying to do, because at least in Lynch syndrome, I don't think it's going to be, this crowd is probably well familiar with it with all the COVID. It's not going to be a univalent or bivalent vaccine. It's probably going to have lots of different epitopes that are needed. And the only kind of the only way to actually deliver those different epitopes or different foreign protein mimickers is going to be through mRNA vaccines, which you can change the nucleotides very easily. So I think that is actually going to be a game changer in a lot of the cancer vaccines that need to have very specific types of vectors to stimulate the immune system.
Mm-hmm. Yeah, very exciting work. Okay, well, thank you very much, Raymond. Appreciate you being here, taking the time, and delivering that very, very informative talk. We're going to go on now with Professor Tay Hart. Tay Hart works with us at the Zane Cohen Centre, but she's also a professor of psychology at the Toronto Metropolitan University, which, as you probably know, used to be Ryerson University. And she's an associate professor in the Department of Psychiatry at U of T as well. And she's going to talk about mainly about patient perspective on gynecologic screening and surgery. Very important topic, because as you know, Lynch syndrome is not just colorectal associated with colorectal cancer. There are multiple cancers that are associated with Lynch syndrome, the gynecologic cancers being the most common. So very important topic, as I said, and I'm sure that everyone is interested in this as well. So Tay, patient's perspectives on gynecologic screening and surgery. Take it away.
Here we go. Sorry, everybody. I didn't realize I was muted. I'm Tay Hart. Thanks for having me. I'm going to be talking about results from a research project. And the title of this talk is Patient Perspectives on Gynecologic Cancer Screening and Surgery. And I just want to acknowledge my co-investigators, Helen Hubben, Caitlin McGarrigle, Melissa Aronson, Kara Simodiak, Thomas Ward, Sarah Ferguson, and Zane Cohen. So I want to just talk a little bit about that risk management strategies for gynecologic cancers associated with Lynch syndrome are diverse. They range from the CA-125 blood serum test, transvaginal ultrasound, endometrial biopsy, and risk-reducing surgery. But the gynecologic cancer risk management guidelines for women with LS can be confusing, and it can make it difficult for women to make decisions about how to manage this risk. And what's interesting is that research data are really lacking on the challenges that women with Lynch syndrome face in gynecologic cancer screening. And that was the purpose of this study that I'm going to present to you today. So we looked at, among women with Lynch syndrome, the psychological and social factors that influence gynecologic cancer screening, as well as the unmet information and healthcare access needs when making these decisions. And women with Lynch syndrome were recruited from two sources. The first was the Familial Gastrointestinal Cancer Registry at the Zane Cohen Centre for Digestive Diseases at Sinai. And the second was the gynecologic oncology clinic of one of our study investigators who specializes in Lynch syndrome-related gynecologic cancer risk management. And to be eligible for the study, you had to be over age 18, have a confirmed Lynch diagnosis, have an intact uterus and ovaries, so no risk-reducing surgery in this particular sample, and the ability to provide informed consent. And this is a qualitative study, so there's only 20 participants, which is typical of qualitative research. And we looked at two groups of women. The first group was comprised of women in the screening group who were between the ages typically of 30 to 40 years. And the second group was comprised of women in what we call the pre-screening group. These people were all under the age of 30, as surveillance typically doesn't start until age 30. And we put together a series of questions for our semi-structured interviews. So after providing informed consent, all of the interviews were conducted over the phone and they were audio recorded. And interviews ranged from anywhere from like 30 to 60 minutes. We then uploaded the audio recordings to our secure network at Sinai. We transcribed the interviews verbatim, and then we reviewed these transcripts for accuracy and to ensure that data were anonymous. And so in terms of how we analyze these qualitative data, we use something called thematic content analysis, which is a commonly employed qualitative data analysis technique that interprets meaning from the content of what people say. And we reviewed all of these transcripts. We then derived a code book which had themes and sub-themes and quotes and examples. And then using this code book, we coded all of the transcripts. And then we reviewed those coded transcripts as a team to ensure unanimous decision-making. What I want to do right now, before we get into what did the qualitative data show, I wanted to talk just a little bit about who are the people in this sample. So you can see here that people in the screening group tended to be around age 33, whereas the pre-screening group, which I mentioned, were all women under the age of 30. The average was about 26. The majority of the participants in the research were partnered or married, identified as white, were working either full-time or part-time, and almost everybody had at least one or more family members with cancer because these are coming from Lynch families. In terms of the genetic defect that people had, you can see it's pretty widely distributed across the screening group, whereas the pre-screening group, there were 2 people with MLH1 and 4 people with MSH2. In the screening group, 5 people had already had cancers, but not gynecologic cancers. 3 of them were gastrointestinal cancers. 1 person had had lymphoma and 1 person had had melanoma in the past. And 1 person in the screening group had 1 ovary removed for a non-cancer reason. So in terms of the qualitative data, what did we find? So the first theme was how people understood their level of risk for gynecologic cancer. So many people from the screening group talked about being familiar with symptoms that could indicate gynecologic cancer, but the non-specific nature of the symptoms, for example, bloating or urinary frequency or bleeding, was really difficult for people to gauge their cancer risk from that. Women from the pre-screening group were generally less informed about those types of physical symptoms, but they also mentioned, because they had been more newly diagnosed with Lynch, that they had had fewer conversations with their healthcare providers. And also they felt that their young age precluded them from having to know or worry about this specific kind of cancer. In terms of the second theme, this was all about managing gynecologic cancer risk. Most of the women in the screening group, I'll just put this bluntly, were embittered by their experience of undergoing endometrial biopsy, reporting pain, discomfort, and a lack of pain management as a major driver of their dissatisfaction. But despite the pain and the uncertainty of not knowing if the biopsy sampled all malignant cells, people said that they were still motivated to undergo biopsy, especially if it was recommended by their healthcare provider. Managing gynecologic cancer risk also had a number of psychological impacts that people spoke about. Anxiety, especially with GPs arguing to get the gynecologic cancer screening. And then a few people were the only woman in their family with Lynch. And so they felt they were navigating uncharted territory, at least in terms of their family experience. People also talked a lot about having the right kind of information from the right people versus having too much information, which could impact their anxiety. And so it's talking about the risk of Googling or finding incorrect sources of information. And finally, people talked about how getting a colonoscopy was much more straightforward and reassuring compared to their gynecologic cancer risk screening. The third theme that came up from the data were about interactions with the healthcare system. So people in both groups talked about positive and negative interactions with their healthcare providers. Positive interactions involve things like receiving emotional support, receiving information, and getting comfort from their healthcare providers. The negative interactions, which I alluded to in the last slide, were having to argue to get screening, having to self-advocate for screening procedures, and especially with GPs having to educate them about Lynch syndrome. People also talked about, in both groups, the healthcare system not taking women's health seriously. And they described concerns about lack of funding for women's health research and care, cancer symptoms, like I mentioned to you, several people had cancer, not gynecologic cancer, but with colon cancer, those symptoms being written off as menstrual symptoms. And then a sense of frustration and resentment of being failed by the institution of healthcare for women living with Lynch syndrome. And finally, both people in both groups, I should say, talked about having to self-advocate when it came to information gathering, scheduling appointments, and also follow-ups. In terms of the fourth theme, people did talk a lot about their considerations about getting risk-reducing surgery in the future. So from both groups, people described concerns around family planning, and everybody had a desire to wait until after having children, if that's what they wanted, to undergo surgery. A few participants did discuss topics like in vitro fertilization and pre-implantation genetic testing. Almost everybody, when the topic of surgery came up, talked about their concerns around managing menopausal symptoms if they underwent this surgery in the future, and some reservations that they had about hormone replacement therapy like depression, breast cancer, and heart disease. People also talked about kind of the seriousness of removing the ovary and the ovaries in the uterus, and post-surgical care, as well as just the general impacts of how that surgery would change their life and their health. And then finally, many people talked about just feeling too young to undergo this surgery, regardless of whatever their childbearing decisions might be. And the final theme, and this really gave us a lot to think about, was around improving Lynch syndrome care. So participants talked about the importance of multiple, reliable, and accessible sources of information, and also having access to informational tools. They also wanted greater access to Lynch-informed practitioners, especially for people not living in the GTA or major metropolitan areas. The need for better coordinated Lynch syndrome care was also emphasized, like having a patient navigator or a case manager, and a better electronic system that would have the ability to schedule all the yearly appointments, as well as screening appointments. People wanted those in the same location and on the same day, which makes a lot of sense. And the final recommendation was to help tools to help women have realistic expectations about the experience of gynecologic cancer screening, and providing trauma-informed care that would allow people to better cope with the stress, the pain, and the uncertainty of yearly procedures. So how does this information kind of add to what we know? So we can see that people from both the pre-screening and screening groups were knowledgeable about their increased risk for gynecologic cancer. And many women discussed and gave us a really good detail around the barriers to screening for gynecologic cancer. There were numerous examples of the interactions with healthcare providers that involved having to self-advocate for one's care, having to seek information on one's own, and finding support from other sources. And finally, as we just discussed, people gave a lot of suggestions about improving LS care, and they also wanted more information about how to manage the impact of menopause if they were to undergo risk-reducing surgery. So I just want to comment that it's a very small study of primarily white women. And we know that Black, Indigenous, and other women of color face significant barriers to adequate health care. And that inequity in healthcare may impact how these results apply to the larger population of women living with LS, who may experience even more difficulties than what we saw here with regards to screening, and also with regard to relationships with their general practitioners in particular. And people were recruited from a large urban cancer center and from the FGICR, which specializes in Lynch. And so people in this study were more likely to have healthcare providers who were adequately informed about Lynch. This study really speaks to the need to provide more information to women on the efficacy of specific screening strategies, and also providing more social support to women with regards to LS, but also managing the uncertainty of screening. Given the level of negative comments that we received around general practitioners or GPs that people had, it's clear that psychoeducational interventions are needed so that the patients themselves are not having to do the job of educating the physician on LS and also how it should be managed. And finally, while we're, as a psychologist, I'm unable to change kind of how endometrial biopsies are delivered. But I think that there's a lot we can do to help prepare people better and to think about strategies to enhance pain management for these uncomfortable screening procedures. And that is about my time. So I'm going to stop the share, and I'd love to hear your questions if you have any.
Well, thank you so much, Dr. Hart, for that amazing talk. And we do have some great questions. So first of all, in your study and speaking with women with Lynch syndrome, did you notice a common theme of perhaps something that women wish they knew before going into screening or surgery specifically?
Well, nobody in the sample had surgery. So we do have a separate sample of women who underwent surgery, and we're currently in the process of analyzing those data. So we have 15 more women that had surgery. It seems like what people wish they would have known is what the data actually were about screening. And they felt like they got a lot of mixed messages. And I think the messages have been mixed depending on who the provider is. Not everybody is up to date on the most current guidelines, and the guidelines do change. And so that is frustrating. That is true. And I think the other piece that people felt unprepared for was what it would feel like, and kind of how to prepare and how to manage that, and wondering, why does it have to be this way? Similar to the questions that we had earlier about colonoscopy, why can't we just be put out? Why do I have to feel anything? How can I get around the prep? How can I get around the uncomfortableness of having to manage this? So that, I think that that's primarily what people wish they would have known.
Thank you.
Mm-hmm.
And you mentioned, ways that we as healthcare providers need to work together to try and educate our colleagues and learn from our colleagues, so that it's not on people who have Lynch syndrome to be educating their healthcare providers. And we all know this is a challenge, one that we do try our best for. But did anyone mention any strategies or anything that they found worked when speaking to their doctors if they were having trouble being referred for screening?
Some people talked about feeling frustrated around having to actually produce evidence. And not everybody has those research skills. So I think having another provider advocate for them, a few people did talk about that. Like, luckily, my gynecologist, knew this person and was able to advocate. But there were few instances of that. Again, it's a sample of 20 people. So it may be that may be more common than we know, just from the sample.
Thank you. And yes, and all of this is, of course, acknowledging that qualitative research is, and we have to use smaller samples. I
do want to comment on. I have been historically a quantitative person, so recruiting large samples of people. The reason why we did a qualitative study is we really wanted to sit down and talk to people about their experience. And this is the kind of data that you cannot get off of questionnaires. It just simply can't be captured in the same way. And so we really wanted people to tell us what their experience was and what they feel like they need to have happen to have a better quality of care.
Thank you. Yeah, and that actually brings up to another point. So we have people joining us from other provinces who are very interested in knowing about across the collaboration between provinces. And do you think that it would be possible in the future for this study or others, to see if what you have learned from the study might apply across Canada, or if it's something that is more specific to certain parts of Ontario?
That's a really good question. And of course, it would be interesting to talk to people that are in Newfoundland or in BC and find out what is happening there. So I think that it would be interesting. And of course, that's always a possibility, even comparing it to the US too.
Right. Just looking at all these questions here. And someone has asked, whether sedation for endometrial biopsy might become a possibility, which, I'm not sure that you might have that answer to that question, but it would be one for your gynecologist or gynecologic oncologist who's managing your care.
Absolutely. But I did ask, I based on the data, I mean, our group has sat down and talked about these data. Many of the people here, Tom, Kara, and Melissa, we've all talked about this. And my impression, and please don't shoot the messenger because I am not a physician and I am not a gynecologic oncologist managing this, but my understanding is that they don't want to put people out for, quote, such a quick procedure. But I did see a couple of comments come through the chat kind of validating what I just spoke about. So I don't think anybody who's gone through it and had not such a great experience feels like anything would be too much. It was not quick. Yes, thank you for that.
Thank you. And another great question. Will there be other phases of this study? And, could one of the goals be to try and include more women of color?
I completely agree with that. I mean, this was an unfunded study. So at the current time, we're not collecting more data, but I do agree that that is a critically important goal. One of my students, Elisa Panjwani, is now a clinical psychologist at UHN, who is a woman of color, who's very interested in this. And so she's back in Ontario. She was in New York getting her degree, and we are hoping to maybe think about pursuing some of this. There was another thing I wanted to comment on though, about other phases. So originally when I designed this study years ago, I had thought that we would produce some educational materials. And as is often the case with research, what you learn from the data shows you didn't have the right idea in the first place. So you never can fall too in love with your own ideas. And so I feel like the next step really here is to produce materials that then people can bring to their physicians and to say, this is the evidence, this is what needs to happen. And of course, some of that the genetic counselors at Sinai have already done and given out, but I think that people have lost that materials, or I think we need something that is probably more accessible. And it would also be useful to talk to GPs to think about how to reach their peers, is another thought I've been having.
Great ideas. Thank you. And on that note, if there's anyone who is interested, we do have surveillance screening recommendation summary sheets. And so if you don't have a copy, please do reach out to us and we would be more than happy to provide that to you, and fax copies to your primary care providers. Just reach out to your genetic counselor and we would be more than happy to help you. And I'm just going to take another look at the chat. Please forgive me looking away. My vision is terrible. So, and you've answered another question about there being a screening tool or app to help, as that's one of the goals. So someone has asked about, after hysterectomy, do they need to be followed by a menopause clinic? I don't know if that's something that came up in your conversations with the gynecologic oncologist during the study.
I will tell you that, menopausal care is something that lots and lots and lots of people are talking about, regardless of Lynch or having risk-reducing surgery. But I do know that it is not standard of care to necessarily refer everybody out to a menopause clinic. I know that because people have talked to us about this. So I will say that it is something that if you're struggling with menopausal symptoms, like lots of things, you're going to have to speak up about it and advocate for yourself.
And another question has been the idea of coordinating colonoscopy and endometrial biopsy been floated as a possibility?
Well, I love that question because I've actually looked this up, and there are places in the US that have what I call like a one-stop shop, but to my knowledge, that is not something that is at least available in the GTA.
Okay. If there's been any other questions that have come through. It's a great question here that, I think back to how to get to this information. How do I get to a genetic counselor? So if you're part of the Zane Cohen Centre, you have a genetic counselor who's been assigned to look after your family. And so you can reach out to our center. I can say the number right now, but we can also send an e-blast with our contact information to our main center, and our administrator, Francis Nipolau, can get you in touch with your genetic counselor who has the most up-to-date information on your medical history from the last time we spoke to you and your genetic information. But you can call us at 416-586-4800, extension 5112. But again, we'll put all of that information in a follow-up email so that you can either easily email us or give us a call. Thank you for that question. I think that's, let's see. People are just, reiterating that it's really good to hear and to have people talking about the experience of pain related to the endometrial biopsies, and because it's something that has not been discussed much or really looked into much in the past, and people are thanking you for this very important work, and want to know, how can we keep this conversation going?
How can we keep this conversation going? I mean, I'm really pleased that the center has, supported this work. And I am seeing more and more research out there. It's something that I've talked about with the Lynch syndrome support group a few times. So I think these conversations are beginning to happen with more frequency.
Thank you. And someone asked about risks of hysterectomy after menopause, and what I would recommend is that you speak to your surgeon or gynecologist, a gynecologic oncologist, about those concerns. They would be the individuals who would have your the best answers for you there. And then there was another question again, Tay, sorry, this is a little bit, I think, fine, regarding, it's related to the aspect that you mentioned about how guidelines are constantly changing. And someone asked, how often should they be in contact with a genetic counselor for updated information about care? And, things are changing. We typically recommend every few years. So, every 2 to 3 years is a good time to check in. We also at the Zane Cohen Centre try to send out update forms every few years, and there's an option to ask questions. So that's another good opportunity to ask questions to your genetic counselor. But I think it's worthwhile every few years to reach out. We also have a newsletter where we do try to provide updates to you, and those go out again every 1 to 2 years as well. So keep up to date on, if you're on our mailing list, you'll receive those as well. And this is another question that would be one that I would recommend that you reach out to your genetic counselor about, because it is very family history specific. But someone has asked if mastectomy is recommended for people who have Lynch syndrome and have family members with breast cancer. So, you know, unfortunately, we can't really answer specific health questions like that in this situation. But do reach out to your genetic counselor. And if we can't answer that, we'll get you in touch with a specialist who can. And so just a follow-up question on how often our newsletters are. Typically, it's every year, I believe. And okay, Tay, Dr. Hart, thank you so much for answering these really important questions and for this very important work. We really, really appreciate it.
Thanks for
Hand
having
it over to Dr. Cohen to wrap up the session.
There were so many questions about discomfort and pain, and I think we should follow up with Sarah Ferguson about this ourselves and ask her what she thinks and how we might be able to mitigate some of that discomfort. Also, the idea of doing a dual procedures at the time of colonoscopy. I mean, that's more of a logistical problem, but a very interesting question as well, which we should ask Sarah about, because that might mitigate some of the discomfort and pain of the biopsy itself. We have a couple of minutes left. Maybe Tom, you could just very briefly give our current guidelines. I know you said you'd send them. Maybe you could just very briefly give them.
Yes. So regarding gynecologic screening, you know, we, like everyone who has Lynch syndrome, who has a uterus and ovaries, to know that screening has not been proven to be effective. However, we do offer screening starting between the ages of 30 to 35 by transvaginal ultrasound and random endometrial biopsy and a blood test called CA-125. And we would be happy if you are that age or beyond and you have not been discussed gynecologic screening or an option for risk reducing surgery to remove the uterus and ovaries, which we do consider after an individual has finished having the children that they intend to have, and once they approach age 40. Again, depending on family history, that can change their recommendations sometimes. If you have not spoken to a gynecologic oncologist and you are interested in learning about your options, please do reach out to your genetic counselor and we can help get you set up with an appropriate referral. I see Melissa has her hand up.
Yeah, I just wanted to say that Tay has presented this data to us, and what's amazing is she started a lot of conversations about how we can help patients advocate, what can we do as a clinic. And so we actually decided to meet with the gynae team that we refer to make sure we're all on the same page as far as screening. We continue to learn about processes that they do. So for example, they do recommend endometrial biopsy for anyone who's going to be having surgery, because they sometimes find cancer randomly, and the best way to find that before the surgery is endometrial biopsy. And they also recommend it to anyone who's I think they said over 45, just as a routine baseline one. So we haven't figured out the problem with how painful it is. And we have also discussed, can we combine colonoscopy and endometrial biopsy? And as Dr. Cohen knows, you would need to reposition people and have, you need to have a gynecologist come down to the endoscopy suite to do it. There were a lot of logistical things, but it's a conversation we started, at least at our center. The problem is there isn't a provincial guideline on this. In fact, there isn't provincial funding to sort of support screening recommendations and reminders and high risk screening like they do in breast cancer. So every clinic kind of does their own, but at our clinic with Dr. Hart and Dr. Cohen, we're really dedicated to trying to help our patients as much as possible. So they're all questions we're trying to look into. And I know Dr. Hart has been trying to figure out, are there other applications to create that might help women with Lynch syndrome?
Okay, I think we'll move on. But the last speaker is Mari Rutka, and Mari has Lynch syndrome, and she has understood or realized the need for further support for Lynch syndrome families, and has actually coordinated a monthly Lynch syndrome support group. And she's going to share with us her own story of Lynch and the potential for advocacy and improvement in Lynch syndrome awareness. So, Mari, I hope you're there, and we look forward to hearing from you.
Thanks very much, Dr. Cohen. I am indeed here, and I won't keep everyone too long because all of you be getting a little bit sleepy. As Dr. Cohen said, well, let's see, I guess it's about 13 years ago. No, it was actually 15 years ago. I started to have a lot of bleeding. I essentially was if you'll excuse me, gentlemen, but my period never stopped. It just kept going and going. I went through 3 GPs who kept telling me it was just menopause, even though I mentioned to them that my mother had had uterine cancer. That didn't seem to make an impression on those first couple of doctors that I had seen. So I kept trying to find a new GP who would maybe do something about it. The third one did send me to see a gynecologist who did one of those lovely endometrial biopsies on me, and told me I'd probably hear something in about 3 weeks. And about 2 days later, they called to tell me that they had the results and could I please come down, that they didn't want to talk to me on the phone. I figured that probably wasn't a great sign. I went down and they told me that indeed I had endometrial cancer. And that was upsetting, of course, to find that out. And I started to think about the fact that my mother had also had it. And then I thought further and realized that there were a lot of other people in my family who had had cancer too. And I will caution you, and a couple of people have mentioned this, you don't want to just read anything on the internet because there are all kinds of crazy, weird things out there. You do want to go to a reliable source. And I was aware and tried to keep that in mind, but I did do some looking on Google to see if I could find out something that might have some sort of genetic thing that might be causing endometrial cancer. And I had relatives who'd had colon cancer. I'd also had relatives who had pancreatic cancer. And so I found this thing called Lynch syndrome, which I had never heard of. But I asked them to test my tumor when they removed it. And sure enough, apparently I had an MSH6 mutation. And thus I was referred to the wonderful Melissa Aronson, one of the excellent genetic counselors at Mount Sinai. And she helped me to learn more about Lynch. And to sort of navigate the sort of what do I do now kind of conversations, and also how to start navigating, trying to inform all of the relatives that I have for whom I was concerned because they might have the same mutation. As it turns out, I now know that at least, I've lost track, no, at least 7 of my relatives have the same MSH6 mutation. And I'm really glad because none of them have had, well, all except one of them has managed thus to be okay. A couple of them have had cancer, but they, so far, we're all still here, and that's actually pretty hopeful. The other thing that I started doing with Mount Sinai is attending their excellent Lynch education nights. And on those occasions, it seemed like there was a need for a support group. And a number of people each time would ask, is there a support group? And there wasn't. So it seemed like a good idea. And Melissa then put me in touch with a lovely person named Teresa Tiano, who had started a support group called My Gut Feeling. for stomach cancer survivors. And as it happens, Teresa also has Lynch syndrome. And so we had a discussion around it, and we decided we would try to start a support group for Lynch syndrome patients. And we got together, and we had great support from the Mount Sinai counselors, and found out that there were quite a few people interested in joining that kind of a group. And so we were all ready to launch with a meeting at Mount Sinai with coffee and tea and cookies, and hopefully a nice welcoming atmosphere. And that was in March of 2020. So as you can all imagine, that didn't quite go as we planned. But we quickly switched to doing online meetings. And that's actually worked out really well for the duration of the pandemic. And we have been meeting monthly. We take a 2-month break in the summer, but the rest of the year we meet. And what do we do at the meetings? Well, we share our stories, we share our experiences, both good, not sometimes bad. It's not always wonderful, but I think it's really helpful for all of us who participate to hear the things that others have gone through. We learn a lot from each other. And I think I think it's been quite a positive experience for all of us. And the advantage to online meeting, I must say, is that it's allowed some people who actually don't live within Toronto to participate nonetheless in our meetings. And some people come every month, and some people just come once in a while. And during our sessions, we always leave time to talk about how we're doing and update one another. And we've also been fortunate in being able to arrange visits from various researchers, some of the folks that are here tonight, like Dr. Hart and Dr. Kim. And in fact, it was just mentioned that Dr. Ferguson would be a good person to be discussing some gynecological issues with. And she's actually going to be speaking with our group in September. We've heard from other researchers and clinicians as well. And many of us, as you know, because we sort of then try to keep plugged into what's going on, have volunteered to help with some of the research that's being done at U of T. And then we also try to share news with each other, again, from reliable sources. I underline that. And in fact, I am going to I have sent Melissa some links that I think you would find some information that you might find interesting. Those of you who are listening tonight, 2 of them are from advocacy groups in the US that put out lots of information on, how to talk to relatives about Lynch, what is Lynch syndrome, and they also do try to keep up on research things and advocacy in the States. Of course, that doesn't help us much here. But I'll get to that in a minute. And then a couple of very respectable institutions that have really sort of come to the fore in the States in terms of doing research and treatment, clinical treatment for Lynch patients. So the Dana-Farber Cancer, the Lynch Centre at Dana-Farber, which is part of Harvard University, and the University of Pennsylvania also has a very good site if you're looking for sort of all kinds of information on Lynch. So Melissa will forward that information to all of the folks I believe who are attending tonight. But as I said, the real thing that I think we're beginning to realize is that there's an important need for advocacy here in Canada as well, because we could certainly use better coordination of care, as Dr. Hart mentioned, and definitely better awareness, especially among general practitioners of Lynch. They now believe, and anyone here who's one of the real medical people can correct me, but I think the latest thing that I had heard was that they think now that probably 1 in 300 people in the population has a Lynch mutation. So that's a lot of people, and a lot of people who are probably not getting helped in the way that they really ought to be helped. And I guess we kind of hope that eventually we might get to a point where it would be similar to the way BRCA mutation patients are helped through all these things. And I know it's possible because, and this is where it is helpful to be in touch with folks in the States. I have seen programs in the States where they have very coordinated care. So It's not just looking at colorectal, it's not just looking at endometrial, it's not, they do the whole thing, and they give each patient, you know, who you're seeing, when you're seeing them, when your next visit is, what you need to do in between. And I think we should be able to do that here, and I hope we can. So, and as a lot of you know, and I'm sure some of you have found, it can be very frustrating to try to do those sorts of things yourself. So if you're interested in participating in the support group, then I would ask you to please get in touch with whichever of these lovely genetics counselors you usually deal with, and let them know. And then what they will do is let me know that you're interested. And I will ask, first of all, I need to see how many people that is, because we have to think about the size of the group we have, and whether or not it might be necessary, for example, to start another group. And anybody who is participating, one of the things that we do take very seriously is confidentiality. So anybody who does participate would be asked to sign a confidentiality agreement, so that anything that is discussed during the meetings is kept within the group and for those meetings. So I try to be very careful of that, because this is, after all, people's medical information. And I know a few people I've noticed in the chat have questions about insurance and that sort of thing. And those can be tricky bits of life to navigate when you've got Lynch syndrome. So we really want to make sure we're not giving away information when we don't want to be. So as I mentioned, we will be on break in July and August, and starting again in September with Dr. Ferguson. And I think we probably will continue to do most of our meetings, at least online, so that people outside Toronto can participate if they are interested. But I'm also happy to say that after 3 years of looking at each other in 2D, we are planning to do an in-person meeting this month, and I'm really looking forward to that. And I hope, I know a few people already have said that they're coming, and I'm hoping that we get to see quite a few of our folks in their entirety on all sides, because that would be really nice. And we'll probably do that again from time to time in the future. And that's about it. I don't want to take you too long. It's 9:01. But that's it. Thanks for listening, and I wish all of you very well, of course.
Thank you so much, Marie. You actually have a bunch of questions if you're willing to answer.
Sure.
So a lot of people asked about how to join the support group. So I'll just reiterate, instead of having hundreds of people write you directly, they're welcome to write Kara, Tom, or I. And I think most people would have my email, because I emailed out the links. So they're welcome to email me and I will redirect them. How many people are in the group, in the support groups right now?
Right. So right now, and this is why, I mean, I've never done a support group before, so it was a new experience for me too, and I wasn't quite sure what would happen. We actually have 60 people on our email list, but we usually have about, I'd say, somewhere between 10 and 15 people at any given meeting. Some people are regulars, as I said, they come every month, and some people come every once in a while. And, you know, it's not necessarily going to be for everyone. So some people may come once or twice and decide that that's enough. Sometimes I think, and that's fine if that's helpful, because sometimes it's just really good to get it off your chest and say how you're feeling and the things that have been worrying you or that you're wondering about. And you will find, I think, if you do participate, that you get a lot from what other people have experienced, because and some of the people that are in our group are really amazing individuals who have gone through a lot of things and are still hanging in there and still doing everything they can. So I think it's actually quite inspiring sometimes.
And you have cancer patients and people who don't have cancer.
Right.
But
so
everyone
we have
has Lynch syndrome.
Previvors and survivors, yes.
How do you come up with the speakers that you're going to invite?
So we just basically keep, I mean, if the need arises out of the discussion. So we, as I said, we always have time each meeting for discussions of where people are and what they're doing, what challenges they've got right now, you know, the things they're wondering about in terms of possible treatments or clinical trials they've heard about, or research that they're wondering what, you know, what does that mean? And then Melissa and Dr. Kim and some of the other U of T researchers and so on have been really great, and Kara and Dr. Hart, actually Thomas, everybody here has been wonderful about suggesting people that could then talk to the group about specific topics. And so that usually ends up being about once every other meeting that we have somebody that comes and shares some information with us. And we've had discussions around not just female cancers, but also male cancers. So like prostate cancer and the things that can be done to screen for that, and how that relates to different Lynch mutations. And we've had discussions around the immunotherapy research that Dr. Kim was talking about, and of course his own research, which is very exciting in terms of being able to maybe not have to have colonoscopies anymore. So that would be super nice. And we've had other people talk to us about, and of course, I don't know if people are aware, and Melissa, I'm not sure if you've had a chance to tell people about the sort of pan-Canada work that you guys are doing in terms of trying to see what's being done in every province, and what's being overlooked and what hasn't been coordinated, and trying to come up with a sort of grand national plan for how we could do this most efficiently. And that's actually pretty exciting work too. So all of those things, but again, a lot of it just arises from what people need and as they tell us they need it.
Someone's asking, what's the duration of the meeting? How long are they?
And again, it's pretty low key. So, you know, I mean, we won't penalize you if you come late or you have to leave early, or if you don't come for 3 months and then you come and then you don't come for another 2. But usually we try to keep, we start at 7 p.m. It's on Wednesday nights. At least that's the group that we have now. And we usually go to about 8:30, sometimes 9 if we really get into some topic that we want to talk about a lot.
Some patients were asking about not being able, their doctors aren't sending them for colonoscopy, you know, every year, or they're having trouble finding family doctors. Do you have any advice about advocacy? How to talk to doctors or how to advocate for yourself? I know you guys have talked about this a lot, but any suggestions for our patients?
Well, I think it takes a certain amount of stubbornness. I can tell you one thing I did that I think probably wasn't good, because I think a certain doctor whose name will not be mentioned, but who was giving me colonoscopies, but would keep saying, well, I'll see you in 3 years. And I kept saying, but I was told it should be 1 or 2 years. So I finally, sort of in frustration, sent him a whole bunch of scientific literature that discussed why it should be 1 or 2 years. The sort of things that we were just hearing about earlier this evening from Dr. MacRae. And I don't think he was very pleased with me, and I'm now seeing somebody else for my colonoscopies. But to some degree, and that's one of the things about trying to improve the coordination of this care. Like people that have the BRCA gene, or even if they have been identified as having heavy, dense breasts, they get on this registry, and then they just automatically get told when their next thing is that they have to do according to, you know, the best scientific study of frequency of testing available at that time. But there is nothing similar right now for people with Lynch syndrome. And that's why I think it would be really helpful. And if any of you are interested in sort of advocacy stuff, please let me know that too, because I think we could use a few people to go down to the ministry and tell them a few things. You know, and there's some, again, the insurance piece is another piece of this that I think the insurance companies need, well, this is a whole nother discussion, and it is getting late, so I won't start. Come to a meeting and we can talk about it, because you know, the way insurance is being done now, I am quite sure that a lot of things that a lot of people have are going to turn out to have some genetic predisposition or component. And if insurance companies keep telling people they can't have insurance because of that, they're nuts, because in fact, it's cheaper to have somebody followed and monitored and, you know, get rid of things before they get super cancerous than it is to have people afraid to get tested and then find out that they have some horrible something that needs all kinds of expensive treatment. So we have to gently persuade people of that.
Yeah, actually, that's an interesting point, because a few years ago, there was enough of a patient advocacy to say to the government, you have to change the laws about genetic discrimination in insurance companies, and they did. So there's now a law saying an insurance company cannot ask you for your genetic results, and they are not allowed to discriminate against you based on it. And that probably came a lot from patients advocating. So we used to warn people, you know, we're nervous about you having to disclose, and now it's illegal for them to ask you. But they can still judge you based on your family history, your own personal history. So they do get around it, but not because of genetics. But you're right, there is an Ontario high-risk breast cancer screening program funded by the government. They give funding to genetic clinics. They automatically remind people when their next screening is. They automatically let family doctors know what results are. And there's no equivalent in colorectal or any other screening for Lynch. So patient advocacy and patient partners are very important in the work that we do.
Yep. So anybody who wants to speak up, please do.
Yeah. So somebody was asking about approaching your family members, and do you have any advice about that? Because it could be a difficult conversation sometimes.
Oh, absolutely. I mean, I think you have to, obviously every family is a little different, and you know best what the personalities in your family are. And I think one of the things you have to do yourself is realize that, you know, you can give people information. They may not always want to hear it, and they may not accept it, but at least you've brought it to their awareness. And I actually had this happen with a couple of my cousins. One of them was willing to hear about it, and I actually think it helped her a lot. She ended up having, I think, the same thing I had, but she knew to look, you know, she was aware that that might be a possibility, so she kind of nipped it in the bud, as it were. But another cousin of mine was not as willing to think about that. So, and unfortunately, that's had some effects too. So I think so don't beat yourself up too much if people don't listen. All you can do is present the information. I wouldn't, you know, announce it to them when you're on a bus ride or, you know, in the middle of a holiday dinner or something. That's probably not the best time. You might want to try to do it more like on a one-on-one basis. If you have an understanding or a feeling about what the dynamics of your family are, and you know, there are certain key people, maybe among your aunts and uncles or cousins or so on, that it might be better to approach than others. I do think, you know, I can tell you myself, I really felt sort of a family obligation to let as many of my relatives know. And when I say many, I actually contacted like second cousins and third cousins that I had never talked to in my entire life, but I knew from family information that these people were related, and I called them up, and after convincing them that I wasn't trying to scam them, but I just wanted them to know about Lynch syndrome, I think it again was kind of helpful for a couple of people. So, but yeah, I think you should, don't feel you have to do it all at once. Don't feel you can reach every person. You probably won't be able to, but you know, every person counts. So if you can help a few people see, or at least be aware that they should be thinking about getting tested, or at least aware that, you know, maybe they have a higher risk for endometrial cancer or for colon cancer or something like that, you're doing them a great favor. So try.
Yeah, that's great. We used to be able to send letters out to relatives to say, there's Lynch syndrome in the family, and if you want testing, let us know. And because of privacy and the, you know, not being able to contact people unsolicited, we can't do that anymore. So really the onus is on the person who gets the results to tell their family, which is a little unfair, but that's how it works. As far as, we can't tell anyone about your results, So you have to do that yourself, and we're not allowed to contact anyone without permission. So our hands are a bit tied. So I just wanted to thank you so much for not only talking tonight, but all of your work with the support group. I know you do really, really great work. And I'll just mention, you're not a physician, right? So because people might be intimidated by, you know, I'm not a scientist, I don't have the background, can I do this? So yeah, the answer is yes, right?
Oh, yeah.
Get
I mean,
involved
yeah,
in
I
your
think,
group, you know.
yeah, I mean, but again, I mean, you want, when you learn information, and especially if you want to share information, you want to make sure it's pretty reliable information and isn't, you know, advocating eating crickets or something, because that's going to cure everything. I would caution people to keep that in mind when you are looking online, or if people tell you stuff. But I think after a while, the more, I mean, you're going to have this for a while, folks. So you might, you after a while, you'll know enough that I think you'll be able to discern what actually like makes sense versus what's kind of, no, I don't know about that. So yeah.
Thank you so much having your perspective. And I know you're working with us on the big national paper, and you know, having your opinion is fantastic. So it's needed in all the research that we do. I don't know if Dr. Cohen is there. There's a few questions that I'll just, that were lingering from before. Someone asked why we call it Lynch syndrome and not HMPCC. So I could take that one. So HMPCC was the old terminology for Lynch syndrome. They're basically the same thing. HMPCC stands for hereditary non-polyposis colorectal cancer syndrome. It's a big mouthful. It implies with the non-polyposis that people don't get colon polyps, and you heard tonight that they do. It also implies that colorectal cancer is one of the only cancers you get, and that's not true. Endometrial cancer is even a higher risk actually in some of the genes than colorectal. So Dr. Henry Lynch is the one who first described it. And at one of the meetings we were at, I remember the whole audience of us said, I think we should call it Lynch syndrome after Dr. Lynch, who was sitting in the audience with us. And he is very humble, as is his son, Patrick Lynch. He's also a gastroenterologist. So they actually call it HPCC, or at least they, Patrick Lynch still does, but the rest of us call it Lynch syndrome. And I think, Dr. Cohen, you might know this. People were asking about treatment for H. pylori.
Well, it's pretty common, as you know, and it's usually triple antibiotic therapy, which gets rid of it completely, and usually one course. So that can cause gastritis, and if you're doing a gastroscopy, you would take a biopsy or take some material from the stomach to prove this, usually a biopsy. So if somebody's complaining of upper GI symptoms and they need, again, their physician recommends a gastroscopy, that's what they would do. But I would like to say a few words in conclusion. This was a terrific education night. I want to thank all of our genetic counselors who, of course, from an unbiased source like myself, are the best group of genetic counselors in the country. They have educated me as well, as much as I can be educated at this age. And I think that more education nights, more support groups, more we can do for patients to help them along is what is really necessary. What I think, if you put the four speakers together, who were all wonderful speakers, and thank you very much for spending the time with us tonight, put it all together, there's so many varied, different aspects of Lynch syndrome that need to be looked at. And the more we can talk about it, the more we can learn. And the questions that arise, like the insurance question, which interests me a lot, and we've had some contact with insurers, but I would really stress to you that if you're having trouble with one insurance agent who uses one underwriter, then go to another one. Just advocate for yourself, because there may be other underwriters who will do different things for you, even if they have to rate you. That's something that we should talk about again at the next education night. Some of the gynecologic problems we should talk about at the education night. We should update some of the research. I mean, there are tons of things that we'll see what some of the studies show with the long-term aspirin use. There are tons of things that we can do, and this is a great learning experience for everyone. So we are perfectly on time. And I again want to thank everyone for registering, for being aware, and send in your ideas, send in your reviews of this education night, so we can talk about them further and learn what are the more important things. That, of course, everything's important, but the more important things that you haven't heard or you have heard, you want expansion on, we're always willing to listen to our patient population. So with that, I will say goodnight to everyone, and thank you, and thank you for listening in, and hope to see you the next time. Good night.
Night. We'll send an email when the recording is up. We did record it, and you'll be able to access it at a later date. Thank you
Great.
so much.
Bye-bye.
Thanks, everyone. Good night.
Good night.